is to recognize the different 4 levels of infection around an implant. Level 1 is pain, redness, and swelling. Level 2 is pain, redness, swelling, and discharge. Level 3 is pain, redness, swelling, discharge, and fever. And level 4 is pain, redness, swelling, discharge, fever, and dehiscence of the wound edges. This was described by Scott Spears about 10 years ago. What you should do is you should try to down-level the rate of the level of infection before you do anything. You do it by first getting cultures and then start with broad spectrum antibiotics while you're waiting for the results. You never treat a patient before you get a culture. And getting a culture meaning that you have to stick the implant, not the implant, in the pocket, get fluid out, and do it under ultrasound if necessary, before you start the patient with antibiotic. If after 48 hours there's no response or worsening, you start IV antibiotics based on the culture result, if you have the result already, and you do that in hospital. If no improvement, you take the patient back to the operating room, and then you explore, you pulse lavage, you exchange or remove the implant, you drain it, and you keep the patient on the appropriate antibiotic. Exploration, drainage, lavage, and exchange of the implant are as important in those patients as antibiotic therapy. These patients have to be acted upon immediately. You cannot wait too long or it will be too late. Interestingly, your ability to save that reconstruction from failing depends on how fast, in an ordinary way, in an orderly fashion, you take them back to the operating room on the right antibiotic therapy after you've cooled down the infection, explore, drain, lavage, and exchange the implant. You will be successful most of the time. Only recently, November 2014, in the Cold Journal, there was a series of 17 patients with infections around implants in both reconstructions and aesthetic surgery. All 17 patients were salvaged by the approach I just outlined for you, which means cooling down, decreasing the level of infection, taking them to the operating room within 4 days, not longer, after putting them on PO, IV, and then exploring them, exchanging the implant, putting a new implant back, draining them in 100% salvage rate. An article just published last week talks about a no-touch technique with a simple device placed over the wound, with the wound edges not being exposed, and the implant inserted into the pocket during reconstruction without anybody touching the implant at all. So this needs to be studied and will be explored further. Interestingly, I mentioned that yesterday, that a systematic review of infection rate is directly correlated to how long you give the patients antibiotics. If you give the patients antibiotics more than 24 hours from surgery, the incidence of infection jumps up from 2.48% to 13.21%. Not only does it give you a much higher incidence of infection, but the infection is much harder to treat because all the bacteria are resistant to the antibiotics that you gave the patient for a week, 10 days, 2 weeks, 3 weeks, etc. Don't put them on antibiotics over 3 doses, at the most 24 hours and stop. Even if they have drains, just keep the drain side clean, aseptic, and treat the patient as we treat any other surgical wound in a sterile fashion. So this is it. Thank you very much. I appreciate being invited here, and I'd be happy to try and answer any questions if